So this is video number 4 in the 6-part video series on hemodynamics and circulatory shock. And in this video, we are going to be talking about cardiogenic shock. My name is Lexi Graham, and let's get started. So first, we're going to be talking about the physical exam findings. Cardiogenic shock is diagnosed after documentation of myocardial dysfunction and exclusion of alternative causes of hypotension, such as hypovolemia, hemorrhage, sepsis, pulmonary embolism, pericardial tamponade, aortic dissection, or pre-existing valvular disease. Some characteristics of cardiogenic shock. So the patient might appear cyanotic and have cool skin and mottled extremities. Peripheral pulses are rapid and faint and may be irregular if arrhythmias are present. Jugular venous distension and crackles in the lungs are usually but not always present. Peripheral edema may also be present. Heart sounds are usually distant, and third and fourth heart sounds may be present. The pulse pressure may be low, and patients are usually tachycardic. And then patients show signs of hypoperfusion, such as altered mental status and decreased urinary output. Exam findings continue. This is more so on the heart defect side. So a systolic murmur is generally heard in patients with acute mitral regurgitation or ventricular septal rupture. The associated parasternal thrill indicates the presence of ventricular septal defect, whereas the murmur of mitral regurgitation may be limited to early systole. Approximately 2/3 of the patients will develop pulmonary congestion manifested as rales on the pulmonary exam. And then the systolic murmur, which becomes louder upon Valsalva and prompt standing, suggests hypertrophic obstructive cardiomyopathy. Imaging studies. So an echocardiogram should be performed early to establish the cause of the cardiogenic shock. This test provides information on global and regional systolic function and diastolic dysfunction. This test can also lead to the rapid diagnosis of mechanical uses of shock, such as acute ventricular septal defect, free myocardial wall rupture, pericardial tamponade, and papillary rupture causing acute myocardial regurgitation. In addition, echocardiogram can reveal akinetic or dyskinetic areas of ventricular wall motion, or maybe demonstrate valvular dysfunction. Ejection fraction may be estimated as well. If a hyperdynamic left ventricle is found, the echocardiogram may suggest causes of shock such as sepsis or anemia. Chest radiograph, these can be useful for excluding causes of shock or chest pain. And then the presence of widened mediastinum can indicate aortic dissection. Most patients with established cardiogenic shock exhibit with findings of left ventricle failure. The radiologic features, which include the pulmonary vascular redistribution, interstitial edema, and enlarged hilar shadows with the presence of curly B lines, cardiomegaly, and bilateral pleural effusions. Alveolar edema manifests in that butterfly pattern that we all know. So these are just a few pictures of the echocardiogram right here. And then this is the chest x-ray. You can see the cardiomegaly and then some of that butterfly pattern that we were talking about. So imaging continued. You can also do a coronary angiogram. This is urgently indicated in patients with myocardial ischemia or MI who also develop cardiogenic shock. An angiograph is required to help assess the anatomy of the coronary arteries, as well as evaluate the urgent for the if they need revascularization. Coronary angiograph often demonstrate multivessel coronary artery disease, which is in short CAD, in people who have been diagnosed with cardiogenic shock. The most common cause of cardiogenic shock is extensive MI, and then after MI, large areas of non-functional but viable myocardium can also cause or contribute to cardiogenic shock. Ultrasound, it can be used as a fluid guide for fluid management. In a spontaneously breathing patient, IVC collapse with respiration suggests dehydration, whereas if the IVC collapse suggests the lack of IVC collapse suggests intravascular evolemia. The ECG, acute myocardial ischemia is diagnosed on the basis of presence of ST segment elevation or depression or Q waves. T-wave inversion may be seen in people with myocardial ischemia. Perform the ECG immediately to help diagnose MI or myocardial ischemia. A normal ECG, however, does not rule out the possibility of an MI, acute MI. Here are a few pictures. We have the ultrasound right here. And then the coronary angiogram shows the pre and post from a patient with cardiogenic shock. And they are demonstrating severe stenosis of the right coronary artery. And then you also have the ECG. This is showing the evidence of an extensive anterolateral myocardial infarction. The patient subsequently developed cardiogenic shock after this. And then this is the hemodynamic side. You're going to be using that Swan-Ganz catheter again. The PCWP will be higher than 15 millimeters of mercury, and the cardiac index will be lower than 2.2. With the presence of large V waves on the PCP tracing, this suggests severe mitral regurgitation, whereas a step up in oxygenation saturation between the right atrium and the right ventricle is diagnostic ventricular septal rupture. High right side filling pressures in the absence of an elevated PCWP when accompanied by ECG criteria indicate right ventricular infarction. And also systemic vascular resistance may be slightly elevated in cardiogenic shock, but not excessively high. Medication options. So you can use aspirin or heparin for patients who have an MI or acute coronary disease. Dopamine is the most commonly used drug to improve cardiac contractility and can be also used to increase myocardial oxygen demand. Dobutamine is preferred if this is diastolic, if the blood pressure is higher than 80 millimeters of mercury. Diuretics can be used to decrease plasma volume and peripheral edema, trying to get rid of some of that fluid that may be impeding on the heart. The reduction of extracellular fluid and plasma volume associated with diuresis may initially decrease cardiac output and consequently blood pressure with a compensatory increase in peripheral vascular resistance. With continuing diuretic therapy, the plasma volume and peripheral vascular resistance should usually return to pre-treatment values. You can also use inotropic or vasopressors for patients with inadequate tissue perfusion and inadequate intravascular volume to maintain the arterial pressure of 60 to 65. And then vasodilators are used to relax vascular smooth muscle and reduce the SVR, allowing to improve forward flow, which improves cardiac output. ABG anomalies. So these values will show a metabolic acidosis with elevated lactate levels, and hypoxemia will be present. Mechanical ventilation options. So you can use non-invasive first, CPAP or BiPAP, for those not quite needing mechanical ventilation yet. The patients include those who are hypercapnic, increased work of breathing, or if they have moderate to severe acidosis. If you are using mechanical ventilation, you're going to use the volume control Sysco to help balance that blood gas, and then the optimal PEEP levels to protect those lungs. The concerns with positive pressure ventilation, although they may improve oxygenation, it may also compromise venous return, the preload to the heart. If this happens, cardiac output will be decreased due to the increase in intrathoracic pressure that is causing the decrease in preload. This can worsen the patient's condition, particularly in cases of right ventricular dysfunction. An increase in afterload is also a concern because it can further compromise cardiac output. If any other previous complications occur, this can lead to the patient becoming hemodynamically unstable and possibly risk making them worse. So back to those. minimal peak pressures. So in summary, we talked about physical exam findings, which let's recap. That included mottled skin, cyanotic cool skin, faint peripheral pulses, or they'll be faint and rapid. Jugular venous distension, distant heart sounds, crackles in the lungs, tachycardia, and hypoperfusion is normally present. Imaging, you can do echocardiogram, chest radiograph, coronary angiogram, ultrasound, or ECGs. Hemodynamics, we just went over. PCWP is greater than 15 millimeters of mercury. The cardiac index is less than 2.2. The SVR can be slightly increased. For the ABGs, you'll have the metabolic acidosis with high lactate levels and hypoxemia. Medication options, you can use the aspirin, heparin, dopamine, diuretics, inotropic agents, or vasopressors. And then for mechanical ventilation, BiPAP or CPAP before, and if they need more support, you can put them on mechanical ventilation, on volume control, sys control to balance out that blood gas, and for when you have those optimal PEEP levels. And then the issues you want to watch out for, like we said, was you don't want to decrease their venous return and increase those intrathoracic pressures, because that will then react what we've done, making the patient worse. So that is all I have for this video today. So thank you for watching.